Hi, everyone, and welcome back, or hey, just welcome if this is your first time listening to Blood Bank Guy Essentials, the podcast designed to help you learn the essentials of transfusion medicine. My name is Joe Chaffin, and I am your host. Today's episode is a discussion on a part of patient blood management that I believe is just being ignored way too much. My guest is a true leader in the field. His name is Dr. Aryeh Shander from Inglewood Hospital and Medical Center in New Jersey. And more on Dr. Shander and today's topic in just a second. Before that, though, you should know that this episode is not eligible for continuing education credit. You can find other episodes where physicians and laboratorians can earn CE credits for free at bbguy.org/podcast. And there you just look for episodes that end with the letters CE, or just visit wileyhealthlearning.com/transfusion news. The continuing education episodes are brought to you by transfusionnews.com, and Transfusion News is brought to you by Biorad, who has no editorial input for this podcast. So I don't think that you can be involved in transfusion today and not have heard at least something about patient blood management, or PBM as we abbreviate it. Most everyone is aware that PBM programs involve things like improving physician blood ordering practices by quote unquote tightening up approved thresholds for transfusing red cells and platelets especially. Many have heard cute little phrases like, hey, why give two when one will do, to describe current thoughts on transfusing 1 unit of red cells as a default instead of 2 units as a default. And some might also know that good PBM programs also emphasize reducing unnecessary blood draws and promote innovative methods of reducing blood loss during surgery. All that's great. What I'll bet many do not know, however, is the fact that you can do all of those things and you can still miss what may be, in my opinion, pretty close to the most important part of patient blood management, and that is detecting and managing pre-operative anemia before the patient is ever admitted. I call it the forgotten pillar of patient blood management, and Dr. Aryeh Shander wants you to know just how important it is. Dr. Shander is a hugely important voice in patient blood management. He is an anesthesiologist. He is, in fact, the emeritus chair of the Department of Anesthesiology at Inglewood Hospital and Medical Center. His publication list is seriously, it's longer than my arm. It's ridiculous. And he still lectures extensively and internationally on PBM topics. He's a giant in this field, and you should listen to him. This episode, by the way, is the second in my, well, I would call it a friendly collaboration with the Society for the Advancement of Blood Management. That's SABM. You can find their website at sabm, SABM.org. And I'm very grateful to SABM for helping to arrange this interview. In fact, Dr. Shander is a past president of SABM, and I highly recommend that you check out their resources and website. And now I'm really, really happy to present my interview with Dr. Aryeh Shander, which I call Patient Blood Management. What are you missing? Aryeh, thank you so much for being with me on the podcast. Welcome.
Thank you, Joe.
It's an incredible honor to have you here. I have read things that you have written, heard you speak on many occasions, and I am a big fan of your approach to patient blood management and transfusion in general. And I wonder, as we get started, Aryeh, if you wouldn't mind, I can't before we get to the topic we're actually going to discuss today, I can't help myself but ask you, if you were in a position, and I'm guessing you don't get put in this position very often anymore, but put yourself maybe 10, 15 years ago when someone was saying to you, Aryeh, this patient blood management thing, what the heck is that? If you were explaining this patient blood management to someone who was just learning about it and just trying to figure out what to do, how would you just thumbnail it or give an overview of patient blood management?
Well, thank you, Joe. First, I want to thank you for giving me the opportunity to be on this podcast. I think it's important for our listeners to understand all these issues that you just outlined. And to start with, I think that the answer to your question is not really that involved, because what has happened over the last century, in a way, has been that transfusion has taken this sort of a central role and has become a default treatment for all kinds of anemia and hospitalized patients. And I could actually spend a whole podcast just talking about transfusion, which is a therapeutic approach without ever mentioning a disease that we're treating. This is how skewed things have become over the years. The essence of patient blood management is really going back to the medical model, identifying what is the disease. And clearly we're talking about anemia, but keep in mind anemia may have different etiologies. So if it's iron deficiency anemia, the therapy is going to be very different than if it's inflammatory anemia or anemia of chronic disease, as most people refer to it. In addition to that, the workup of a patient with these different anemias is going to be very different. So the issue is we are looking at, from a patient blood management point of view, we're looking at disease management, putting the patient in the center, and therefore selecting the best therapeutic intervention for that particular underlying disease under any of the circumstances of the disease, which means, as you know, when a disease first appears, it's very different than when it's been around for, say, 15 years in the same individual. So the chronicity of the disease may also alter the therapy. So essentially, we're moving from just using a product, or as we call it, component, as a therapeutic agent. We're going back to the medical model where we put the patient at the center and look at what disease they have, make the right diagnosis, and then apply the correct therapy.
Very nice. Well, just out of curiosity, Aryeh, is this approach and this feeling about considering the overall management of the patient and not defaulting necessarily for transfusion? Is this something that you've had your whole career, or is this something that developed over time for you?
No, I have to admit that, I was swept with the same issue of transfusion medicine in early days, where we only thought of transfusion as the only intervention for patients who had anemia. We're also expanding this in many ways to look at coagulation abnormalities with the use of plasma, which is now today being critically looked at, and of course platelets. And there are now other derivatives of blood components such as cryo. So these are appropriate therapies, and what we need to do is, again, look to where the disease state is and what kind of defect it is that we need to treat. And, sometimes blood components are the right thing. But in many cases, we're seeing that we could care for patients without issues, without, again, resorting only to blood components.
Well, so I wanted to take the opportunity today to have a conversation with you about a topic that I know is very near and dear to your heart. I mean, I think when you look at patient blood management, the part that we're going to look at today is really, for me, and this is my editorializing for a moment, Aryeh, when I consult with hospitals, as I do from time to time, about establishing or improving patient blood management programs, they're very happy to talk about, making those doctors transfuse better by knocking hemoglobin thresholds down to 7 and things like that. They're okay with talking about intraoperative methods, and sometimes okay with talking about decreasing the amount of blood drawn post-op. But one thing for me, and I would love your feedback on this, one thing for me that I find a lot of resistance to is evaluating patients preoperatively for anemia with enough time to do something about it. Is my perspective skewed, Aryeh, or do you see that as well?
No, we see that. It is an issue in terms of interfering with what is currently the production pressure. So, but if you look at it from the point of view of the patient, let's take a large joint replacement. Let's say it's a hip or a knee joint replacement, or even a shoulder, where it's an involved surgery. These patients go to surgery after years of having progressive debilitation, if you will, or pain over the years, until the surgeon feels that this is the time to do the joint replacement. Anemia may have been present for all those years in that patient and essentially been ignored because it could be easily treated with a transfusion. So by saying to the surgeon 3 weeks or 2 weeks prior to surgery that, hey, this patient is anemic, and anemia has, as you already know, Joe, anemia does carry an increased risk of morbidity and mortality to surgical patients. And now we know it's not just the surgical patients, but most likely all hospitalized patients. We need to step back and do the appropriate thing, which is make the right diagnosis, knowing what the anemia is caused by, and then making the appropriate therapy so that the patient's risk, which is modifiable, which is anemia, can be addressed prior to surgery, improving outcomes. So yes, there is resistance because of the production pressure, but there are ways of, again, educating our colleagues that this is the right thing to do. Now, we would not take the patient if they had evolving cardiac symptoms. There's no reason to separate out the hematologic versus the cardiologic system in terms of saying, well, we can ignore one and not the other, because both of them carry risks which potentially are modifiable.
And that brings me to kind of my first question in delving into this. You and I both know anemia worldwide certainly is an incredibly common diagnosis, and that's certainly true here in the United States as well. Perhaps not as much as in less developed countries, but it's obviously very common here. Do you feel that clinicians underestimate the impact of anemia in general?
Absolutely. And I think they have traditionally ignored it because it's a silent disease until it becomes critical. So as you mentioned, over 2 billion people around the globe have some level of anemia. So this is an epidemic by all means. In addition to that, about 500 million of those are women in their childbearing years. And we do have data looking at both gross national product as well as contribution to economic efficiency. And we both know that, again, the data shows that anemic patients produce less in terms of the social responsibility. But in addition to that, they may also have, on a personal level, they may have difficulty in terms of their daily activities. But otherwise, it's silent because everybody probably feels a little tired. Everybody feels a little foggy. Everybody feels a little of this or that. So again, when you have a hemoglobin, say, of 10 or 11 grams per deciliter, the physician is more apt to say, you know what, it's not that bad. And since there are no acute symptoms, we're just going to ignore it.
And just for clarity, just so everyone, obviously people listening to this are going to be at varying levels of expertise. When we say, quote unquote, anemia, is there a standardized definition for that, Aryeh?
That's a great question, Joe. And we tend to look at hemoglobin, which is a concentration. In the United States, it's measured as grams per deciliter. So it gives you an idea of the weight and the amount of volume. Unfortunately, what we really need to look at is the number of active red cells in the circulation. We don't have a non-invasive, meaning a simple way of getting that number. So we have to rely on what we call a surrogate measure, which is hemoglobin. And the World Health Organization over 60 years ago looked at a distribution of hemoglobin concentration amongst multiple populations and came up with a Gaussian distribution and arbitrarily cut off male at 13 grams or below, females at 12 grams or below, and the pregnant woman at 11 grams or below. This is now being revisited because there's a lot of disagreement, both in the hematologic literature, but also amongst us, that the concentration probably should be the same, meaning 13 grams per deciliter, but that the total blood volume and red cell volume may be differed. But as I said, we don't measure it. So I think we're going to see a change that for adults, it's going to end up at one number, which is 13.
I see. Okay. Well, and that's actually a really interesting and important discussion, because one of the things that I've had many discussions with people about when they're talking about patient blood management. And this is a slight sidebar, but I'd love to get your take on it. I am long on record as stating that in the old days, quote unquote, when people used to use a trigger of 10 grams per deciliter of hemoglobin to transfuse people, that was silly. But now I fear that the pendulum has swung the other way, and I hear people saying very strongly any transfusion with a hemoglobin over 7 is obviously automatically inappropriate. And I think that's just as silly. So again, I know this is a sidebar, Aryeh, but I wonder if I could get your take on how. My position is those are numbers, and we're not treating numbers, we're treating patients. And I don't want to influence your answer. Obviously, I couldn't. But how do you feel about that argument?
Well, I feel exactly the same. I think hemoglobin is just one number. And to use hemoglobin as an indication for a transfusion clearly overlooks the fact that you may have different levels of hemoglobin with the same red cell mass, depending on your plasma volume. So, and that's what's really important for oxygen delivery. Everyone lives with this formula that's been created for oxygen delivery, which is the cardiac output times the carrying capacity of oxygen, where hemoglobin plays a major role. But that's a calculation. That is a formula. When you're actually doing the measurement, the response to the increase in hemoglobin varies significantly when you're giving banked blood. So this becomes a real issue with people using a single number. You really have to take in the clinical aspects of the patient, clearly the surgical situation, and if you're looking at blood loss, should be another consideration. But using a single number by itself may actually end up with an inappropriate therapy and an inappropriate amount of blood being given to the patient.
So before we dive into specifically preoperative anemia screening and evaluation and treatment, I wonder if you could just briefly discuss for us, again, just speaking of anemia in general, and you've mentioned some of this already, but do we have data and information on how specific organs or specific systems are impacted by anemia, again, just in general?
That's another very good question. So yes, we're generally talking about total body outcome when we're looking at population. But we do have data in terms of oxygen delivery and reserve, rather than the impact of anemia. And we know that each organ, including the heart and the brain, have significant amount of reserve. Now, when that reserve is consumed, what happens is we generally go into what we call supply dependency or anaerobic metabolism. And we produce lactate. Now, everybody worries about that. But in fact, if you look at it from a purist point of view, anaerobic metabolism is just inefficient, meaning you don't have enough oxygen. So you're diverting the energy production through a different mechanism, which is less efficient, and you produce lactate. Clearly, supply dependency of the worst kind, meaning when there's no reserve and is prolonged, may have some damage to the organ. And the organs that generally don't do well with supply dependency include the kidneys, which I would put as number one. But of course, the heart and the brain are another. And there are probably some other endocrine organs that also suffer. The lung, on the other hand, has varying responses depending on the amount of fluid the patient has on board. So, to go back to this issue of the reserve of organs and the impact of anemia in organs, it takes quite a while before you actually get a significant impact because of two things. One is the compensatory mechanism of both the organ and the body to anemia in terms of trying to preserve oxygen delivery. But today, we know that there's another element which we were not aware of years ago, and that is the genetic expression that occurs during reduction of hemoglobin and oxygen delivery. And those of us who have what's called HIF1, it's a hypoxic-inducing factor 1 and 2. What happens during hypoxemia is there's a change, immediate gene expression for the HIF, which again, it protects the organs from necrosis. They convert from necrosis to what's called apoptosis, which is organized death, which preserves the organ, versus a disorganized chaotic death, which is necrosis, which does not preserve the organ. And those individuals who have the gene expression do very well with very, very low hemoglobin. I could tell you anecdotally that we've had patients with hemoglobins less than 2 grams per deciliter that with aggressive treatment went home to normal life.
Wow. All right, Aryeh, I think we could talk a lot longer about those points. There's a lot of interesting stuff in there, but I think we need to move along to our specific discussion today about preoperative anemia, evaluation, screening, treatment, et cetera. I guess the first and simplest question for you is, so you've talked about the fact that anemia is very common in the general population. Do we have any idea on whether or not anemia is more or less common in preoperative patients?
So yes, the quick answer is yes, we have data, and I will tell you that the data is now decades old. We've identified patients going for large joint replacement or arthroplasty now going on almost 2 decades ago, where we noticed that the range of anemia in that population can be as low as 25% and as high as just over 40%. So if you look at it, we could easily say that 1 out of 3 patients has some level of anemia, which is a modifiable risk that needs to be attended to prior to elective surgery. Now, the range of prevalence of anemia amongst the surgical population is different depending on the underlying surgical condition. So, for example, patients going for right hemicolectomy as an elective procedure for a rectal or, let's say, for a colonic mass can have anemia. Iron deficiency anemia, the prevalence could be as high as 75%. So again, keep in mind that there is some variability depending on the surgical procedure and the underlying medical condition. But in addition to that, we also know that patients coming for cardiac surgery have a significant prevalence of anemia. And again, the production pressure has always been to get those patients into the operating room, where in fact we know today that there are many centers that delay surgery until modifiable risks, including preoperative anemia, are managed. I think what the audience should also understand is that if you come in and you have anemia for your surgery, your likelihood of being anemic on discharge and that the degree of anemia is going to increase. So on discharge, many patients are anemic. In cardiac surgery, there's some data suggesting up to 90% of patients leaving the hospital have some level of anemia, which again is not always attended to as an individual medical condition.
Well, how do you respond to people, Aryeh, that say, well, okay, so I have a patient that has pre-op anemia. Well, of course they do. They're sick. They have whatever it is that they're having to be replaced. They're chronically ill because they need a new hip. I'm just pulling something out of the top of my head. But how do you respond to people that just suggest that, well, it's just due to whatever disease process is going on?
Well, I'll divert to another disease situation. Okay, how about diabetes? So if you're diabetic and you're under stress, your blood sugar is going to be elevated, which again is not a good thing for a diabetic patient. And we tend to say, okay, hold off. Let's see. The surgeon may call the internist or the endocrinologist who's taking care, or the diabetologist who's taking care of this patient, to get things adjusted to reduce the risk if it's modifiable. We do the same thing for cardiac surgery or cardiac conditions. If the patient now has some abnormality on their electrocardiogram or they are symptomatic, we try to evaluate that and see what needs to be done prior to surgery so that, again, we minimize the negative outcomes that can occur if the risk is not modified. So I think the same principle as we mentioned earlier in the podcast of how we address all medical conditions really should apply to anemia. Now, the argument, and I think that's behind your question, is, well, many people say anemia is just an expression of the underlying disease and not a disease in itself. All I could say to those individuals is that while you're arguing back and forth, I know what to do for this condition of disease. And it usually requires a diagnosis and therapy, just like any other disease.
Sure.
We could split hairs, but in the meantime, we got a patient needs care.
Absolutely. Boy, I could not agree more with that. That's an excellent point. Well, so let's talk about then, if we have a patient who has pre-op anemia, whether it is diagnosed or not, and we'll talk more about when to screen and all that in just a moment. But what are the potential negative consequences of someone going into a surgery who is anemic? You already mentioned being discharged at a level of anemia, but are there other things that could happen or are more likely to happen?
Those are very good questions. So again, we have a couple of large data sets that we could look at. So the first data set that I'm going to refer to is large observational trials looking at outcome in surgery of anemic patients. And, whether it be data that's gone from NISQIP, the surgical risk pool that's out there that collects data on all surgical patients, or whether it's, again, European registries, we all know that patients, if you just use anemia as your only measure in terms of risk, is an independent risk factor for increased morbidity and mortality. And that, by the way, extends not just to the adult population, but there's work being done and published from Boston showing that also in the pediatric population, it resonates with the same type of risk of morbidity and mortality. The other data out there shows that 94% of transfusions are due to three areas that we know can be modified. And the first one is anemia. The second one is blood loss. And the third is the default of treating patients with a transfusion who are hospitalized, whether they're surgical or not. So I'm going to just zero on the first one, showing that, again, one of the major risks of anemia coming into hospital is the risk of allogeneic transfusion. Now, that would be okay if an allogeneic transfusion only conferred benefit to the patient, was low cost, right, and did not cause any type of negative outcome. And we all know that that's not the case. So again, large data sets show the risk associated with transfusion as well as the cost of transfusion alone without adding the cost of any complication. So is it avoidance of transfusion that we're looking for? The answer is no. What we're looking for is the appropriate management of the perioperative surgical patient who has a modifiable risk, this one being anemia.
Mm-hmm. I think that's very, very well put. And I think what you just said kind of answers the discussion, or at least the accusation, that's probably a better way to put it, of people that suggest that someone like Aryeh Shander is anti-transfusion. I think that is an incorrect way to put it, when what you just said is you're looking at it as not necessarily a default, but potentially as part of a portfolio. Is that a better way to put it, Aryeh?
Yes.
Okay. Very simply, yes. Okay. One thing before we leave that, you had mentioned that blood transfusion is not cheap. And one of my very favorite papers that you've ever been involved in, and I've read a lot of them, is something that you did. I believe it was in Blood in 2008, which was an analysis of how much blood transfusion really costs. Do I have that reference right, Aryeh? Was that
was in, yes, it was actually in transfusion, and It was the activity-based costing of red cell transfusions.
Got it. And just for those who haven't read that, now I will make sure I have that reference on the show page for everyone to see it. I mean, cost is part of this discussion. It's not the most major part, obviously, but I wonder if you could thumbnail what you described in that paper.
So actually, I'm going to tell you that paper is a result of research of over about 10 years. What we did first is we got together, and I'm not sure if it was, I think it was around 20 both U.S. and European transfusion experts around the table. And the tasks that they were given was to actually list all of the steps that are required an individual to attend to when we collect blood from vein and then transfuse a patient on the other vein, if you will. So it's vein to vein. And they had to agree that those steps were only steps that were taken for that activity. And they came up with a little over 90 steps.
Oh, wow.
And what we did was we published that and looked for peer review comments, including rebuttal, which none came. And we waited the adequate time for response, and we got no letters to the editor, and no one ever basically complained about it. So we went ahead and used those 90 steps, clocked each one of them, and looked at 4 hospitals, 2 in the United States, 2 in Europe, 2 who were analog and 2 were computerized blood bank, and 2 were community, 2 were academic centers. So we felt we covered most of what we needed, and then measured those steps in terms of what it costs to transfuse a unit of blood. So the true title is the cost of transfusion, not the cost of blood. And what we did is use the cost of blood, meaning the hospitals buy blood for blood centers most of the time, unless they produce their own. And what we came up with, sort of a rule of thumb, is that the cost of transfusing the unit of blood is anywhere from 3.5 to 4.5 times the cost of procuring that unit of blood.
Wow. That's surprising to people, I'm sure. And I still run across people that say, isn't transfusion free? Actually, I'm sure you do as well.
In some countries, that's the way it is. The cost is absorbed by the health ministry and not by the hospitals that transfuse. But as you know, there's no free lunch when it comes to someone's paying.
Someone's paying, exactly. Okay, so thank you for taking that little sidebar with me, Aryeh. I want to get back to our looking at preoperative surgery patients to screen them for preoperative anemia. So let's bottom line this. In your opinion, what is the optimum time to screen a patient prior to surgery for preoperative anemia, and how do you do so?
So that's another great question. So the optimum time has been published over and over again, and it's anyway from 28 to 30 days. Now, why 28? It's because I guess there's some payment issues. But we're doing basically the workup as an outpatient and can use codes for anemia with a proper diagnosis if revenue or reimbursement, as people call it, is an issue. But 30 days allows you for a few things. Number one, it allows you for even a slow laboratory to get the results done so that you can make the right assessment in terms of the cause of the anemia. If the anemia now points to maybe another underlying disease, which I'll explain in a minute, then it also allows you to address that, and also gives you the opportunity to try and treat the patient for their anemia. Now, when I say opportunity, it's because there are some patients who may not respond to the therapy, but at least they've received the opportunity, have gotten the opportunity to be treated appropriately. Now, there are a couple of scenarios. So if, for example, this is let's say a 63-year-old male going for a left knee replacement, and on the diagnostic panel for CBC, we suspect that the patient has iron deficiency, and we then do the iron panel, and lo and behold, we've diagnosed iron deficiency. That individual with iron deficiency is very different from a 22-year-old woman who has iron deficiency anemia. This gentleman needs to have a GI workup, whereas the young woman most likely either has heavy menstrual bleeding, HMB, or again is just iron deficient from blood loss, from menstrual blood loss. So you see that it not only helps in terms of the anemia diagnosis, but we're also now picking up some other risks the patient may have and addressing them appropriately. There are other scenarios like that, but the algorithm clearly that have been published clearly address all of these side alleys.
Right, and you have published that in modified form in several, in at least 2 different papers that I've seen, and I will make sure that again that those references are on the show page. One in particular has a very, very nice flow chart. Essentially, I believe that's the one that you and Tim Goodnow published not too long ago. That has a very nice flow chart.
Well, there's one from that Todd that Tim published for orthopedic patients. Ours, I think, was in 2005, where we had an internist involved because we wanted the internal medicine, community to recognize that they're going to be instrumental in treating these patients. Now, I just want to say one other thing, Joe, and that is, and you actually framed it well. Ideally, we're looking at a month, but we'll take any amount of time.
That makes sense. I mean, I guess the obvious question is there a point that's just too darn little time? I mean, obviously the day before would be too darn little, but
I would say the minute the knife falls on the skin.
Okay. That's fair enough. I mean, I think what that brings me to, and what that the question that raises in my mind is when facilities are establishing this part of their patient blood management program, it seems clear that it's important not just to get the data, but who's evaluating the data and what you're doing with that data. Do you see that as a kind of a hole in this sometimes?
I think it has to be sort of a stakeholder concert team approach. So, yes, we need to, first of all, be able to identify patients going for elective surgery. So that could be a relationship between the surgeons and the booking office with whoever is going to be running the pre-operative clinic, which is generally anesthesiologists. I usually say to my audience that there are only 2 diseases in anesthesiology: malignant hyperthermia and pseudocholinesterase deficiency. We could easily adopt anemia as our for the surgical patient as our disease to manage. They're learning, it just increases your repertoire, and there are now tests that are available to where you don't have to interpret an iron panel, which sometimes could be confusing. There's now something called reticulocyte hemoglobin content, which is a single test that comes with your reticulocytes. And if the number is below 30, the likelihood, or some places 28, the likelihood that is close to 100% of these patients are going to be iron deficient. So you've made the diagnosis of iron deficiency without doing a complex iron panel. Mm-hmm. The interpretation, there's so many references and resources out there on how to construct the pathway, the clinical pathway for anemia detection, diagnosis, and management. I'm not going to go into detail, but I think that it has to be a commitment first, and the commitment has to be from above as well as from below. And once you're committed, your own institutional culture will dictate who's going to be involved and who's going to be in charge and who's going to be the one who makes the diagnosis and how treatment then is applied, either through an infusion center or through a private doctor's office, whatever it is that gets the job done.
Well, and that brings me to a priority question, Aryeh, and I think I know what your answer is going to be to this, but let's just put it out there in as simple a term as possible. And here's my question. What's more important, keeping the surgery date intact or fixing the anemia?
So my answer to that is my department's motto: there's never the wrong time to do the right thing. Nice.
Boy, that is why I don't think anything more needs to be said. I completely agree with you. Okay, so Aryeh, we've talked a little bit about how we screen and when we screen. And again, for those listening, please be sure to check the show page for this episode. You can find it at bbguy.org/podcast and just look for this episode. I will have a ton of references there for you. Aryeh, I wonder if you would take us through just a little bit about some of the facets that we need to be considering when we're talking about the evaluation, especially, and then the correction of these of preoperative anemia.
So I think that the first thing is clearly to look at which surgical procedures should all have an evaluation for anemia. And I would tell you that any surgical procedure that has either a type and cross or a type and screen clearly has to have an anemia evaluation, with the idea that if it's elective surgery, something is going to need to be done. So that's a sort of starting way at the starting line. Then what we need to do is to address where the patient goes to get their pre-admission testing. And that should include either a hemoglobin level or a CBC. Most places will just do a CBC. And once you look at the CBC, if the patient has a low hemoglobin, lower than normal, then the investigation has to be made. Now, you could do a retic hemoglobin content, and if that's normal, the likelihood is that you're dealing with either a nutritional anemia, which would be maybe megaloblastic, such as B12 and folate deficiency, or you'd be looking at anemia of inflammation. Anemia inflammation has two issues. One, of course, is that erythropoietin is blunted, and the other is that iron metabolism is also affected. Those patients who have anemia of chronic disease or inflammatory anemia, we generally look at a creatinine to make sure that they're not evolving into renal failure, which is the most common cause of this particular underlying disease. But arthritis and other and sundry diseases will give you inflammatory anemia. But renal failure is a major risk, as you know, for patients going into surgery, especially if it's in the early stages. You want to do things to protect the patient. So once you've decided, let's say that we have anemia that does not fit iron deficiency anemia, and we really don't think that this is anemia of chronic disease, but we do think that this is megaloblastic anemia, you could look at the size of the red cells and the RDW, which is, again, the range of the different sizes of red cells. And if they're all large, you could then, some places will just treat you with iron and folate, some places will do a level to confirm. Because it's so inexpensive and easy to treat, some places don't want to expend any energy or money on doing the test. So that takes care of the iron and the other nutritional anemia. For anemia of chronic disease or inflammatory anemia, the only therapy that we have is exogenous erythropoietin. And there are label recommendations for erythropoietin in orthopedic patients. And of course, if you're dealing with a non-surgical patient, since you're treating the patient outside the hospital and outside surgery, you may want to use, again, the current anemia diagnostic codes and therapy codes to treat the patient. But erythropoietin will become the mainstay of that therapy. Now, what happens when you give patients erythropoietin is that they produce red cells and release them from the bone marrow very early. Iron gets incorporated into the red cells late in the production. So what happens is that if you don't have iron available for these patients, they will be microcytic. They're going to be making ineffective red cells to sort of be as blunt as possible. So we always, as routine, always add small amounts of intravenous iron to patients who are receiving erythropoietin, or every other day oral iron if the patient is an outpatient for 3 weeks prior to surgery while they're getting the therapy.
Well, let me just address the elephant in the room for just a second with the erythropoietic stimulating agents. There are people that are concerned about the use of those due to the primarily concerned about thromboembolism.
So let me just say this: there clearly increase in thrombosis is part of the side effects of erythropoietin, exogenous erythropoietin. Now, let's compare that with the risk of thrombosis from a single allogeneic red cell transfusion. Mm-hmm. Not much different. In addition, by the way, iron deficiency has been associated with sticky red cells and possibly sticky platelets. So again, another risk factor. What we do know is that from prospective randomized control trials done in critically ill patients, that when you use erythropoietin, what happens is that your risk of thrombosis increases from 3%, which is the general population, to 6%. But if you use prophylaxis, you go back down to 3%. So if you're concerned, and most of these patients are going to be on prophylaxis anyway, but if there's a concern, just treat that concern. There are clearly other concerns in terms of cardiac, and those, I think, have been misplaced and mostly due to very poor structure of the trials that were done. In one of them, which actually was used to again, denounce the use of erythropoietin in cancer patients. The primary author in that particular article had written an editorial where he didn't recount the data that they had, but what he did was say that he himself believes that that's not a concern. And so I think we're seeing a lot of change. You know, it's been over 14 years since the restriction on erythropoietin has been placed because of an aggressive marketing issue. And the FDA responded as well as CMS responded because of the cost of the drug and the possible risks associated with it. But I think we're starting to see more rational loosening of all those because the data clearly supports the fact that on-label use of erythropoietin, the benefit is great and the risk is very low.
Awesome. Well, and you mentioned one other form of therapy that I'm guessing that some people out there may have had given them momentary pause. And you mentioned intravenous iron, and those of us that have been around for a while, I think, recall that there have been some concerns in the past with IV iron, in particular with certain formulations and severe allergic reactions. I wonder if you would address that and what we know about that now.
So that's another very good question. And we do have another one of those consensus statements about the myths about use of iron. So let me categorically say that iron deficiency in a pre-surgical patient, oral iron really has no place.
Wow. That's a strong statement, Aryeh.
I'm making a strong statement. And let me explain to you why. We now know that when you actually prescribe oral iron on a daily basis, what happens is that when you ingest oral iron, the hormone that controls iron absorption and iron transport is called hepcidin. And it is an acute phase reactant, meaning that if you're inflamed, what happens is that hepcidin levels rise and block the entrance of iron through the gut. And interestingly, without any inflammation, if you give oral iron, hepcidin rises and blocks the absorption of iron. Now, you wanted to treat the patient for iron deficiency prior to surgery, you're not going to get the result you need.
Right. Okay.
Now, if you give intravenous iron, hepcidin also rises, but not to the same level and does not interfere in the transport of iron or absorption of iron. And that's why I say categorically oral iron should not be given to patients who have iron deficiency who are going for surgery, and iron deficiency anemia are going to surgery, or even iron deficient, which is a whole other area we haven't addressed. So going back to that, there are different preparations available. The one preparation that has had the most reaction is the high molecular weight iron dextran. And many hospitals have taken that off formulary. As far as reaction from IV iron, there are some reactions in terms of joint pain, back pain, etc. Anaphylaxis is rare. Let's put it this way. If you're concerned about anaphylaxis, the class of drugs you want to be concerned with is not intravenous iron, but antibiotics.
Right.
So let's put the concern where it really should be. But it's not to minimize the fact that these patients, there is a requirement for having test dose in some of the preparations, and there's also a requirement for monitoring of these patients. So we take all that seriously, but most reactions to IV iron are fleeting and non-anaphylactic.
Have we developed any research, any data on what you just said, intravenous iron, and or if you'd like to discuss the use of erythropoiesis stimulating agents as well in terms of the data? Again, we don't have time for you to go into enormous detail, but do we have information that suggests that those strategies work well?
Yes, and I think that we just had one of those with Manuel Munoz accepted for publication in Anesthesia, where it goes really through the whole myths of IV iron in the perioperative period.
Well, Aryeh, before I let you go, I wonder if I could just toss a couple of things at you that people have thrown out as objections to everything that we just, well, not necessarily everything we've just talked about, but the overall process of preoperative anemia screening in general. And I would love to get your take on these. I have heard these personally, so I'm speaking from personal experience, the objections that people have had. The first one that I hear quite often is people say, well, Joe, we're putting in our patient blood management program. We're addressing intra-op stuff. We're addressing post-op conservation and especially appropriate transfusions. So do we really need to worry about correcting pre-op anemia? Isn't this just overkill? How do you respond to that?
So if you're looking at appropriate transfusions, right, as one of your goals, I'm gonna replace it with a different question for you. The real question is not whether a transfusion was appropriate. The real question is whether a transfusion is avoidable. If you're ignoring the underlying condition for which you're going to be transfusing, you will never get to the appropriateness of the care of the patient. You will justify the appropriateness based upon hemoglobin level. But really, the culprit is going to be the fact that anemia was not managed. So not an overkill, nor is it a waste of time. It is clearly if one of your goals is to make sure that your care is appropriate, and as I mentioned, it's not the appropriateness of the transfusion, the avoidance. Would you want to avoid chemotherapy, or would you say chemotherapy is appropriate because you ignored the cancer?
Well put. Absolutely. Okay, one more, Aryeh, if you can hang with me for one more minute. What I hear a lot from smaller facilities that are considering how best to do this is what I would call a myth, and I think you would as well. But people that say that specifically establishing a pre-op anemia clinic is not cost efficient. It costs too much. It delays things too much. And again, you've kind of already answered that, but just specifically for people that hear those objections, how would you respond to that quickly?
Well, again, I think that central to patient blood management is the patient and the disease they're coming with, and trying to, again, modify the risk. So I think that a standalone anemia clinic is not something that I want people to walk away from this podcast thinking that that's what we're promoting. I think what we're promoting is the full gamut of preoperative preparation of the patient by looking at all modifiable risks and, again, managing them appropriately. Now, if you do that, yes, there is going to be an investment. There's no question. But that part of medicine where investments are needed is always, again, countered by the return on investment. And the return on investment today is pretty broad because, number one, you want to reduce disease. That's what we're here for, right? And reduce the burden of disease. That's the other reason we're here for. But now we also have this whole issue of satisfaction. And some of us think probably satisfaction in terms of hotel management, but I think the satisfaction is that we really attended to all of the patient's needs, not just one, which is the surgery itself. And I think that if we can express that to the patient that we're doing that, that's another added return on investment, which may not be monetary, but could be translated into money at some point, as you know.
Well, Aryeh, this has been an excellent experience for me. It's such an honor that you were willing to talk to me and that you were willing to share your incredible expertise. Thank you so very much. I know my listeners will get great benefit from this.
Well, thank you, Joe.
You know, I can't help but feel like I've kind of just been in the presence of greatness. You know, in my experience, finding anesthesiologists who are as passionate about making transfusion part of an overall strategy rather than, as Dr. Shander said, just a default method to correct anemia is really uncommon. And Aryeh's expertise and opinions were fantastic for me to hear. And I know that you learned something too. I thank Dr. Shander for joining me. I thank the Society for the Advancement of Blood Management, especially Dr. Carolyn Burns, for helping to arrange this interview. And I thank each and every one of you for listening. I never take it for granted, and I deeply appreciate your support of this podcast over the past 2 years. Please take a minute to rate the podcast at iTunes so that more people can learn about the essentials. So the next episode will be eligible for free continuing education. I had a terrific discussion with Dr. Chris Tormey from Yale on what we've learned about why people make those darn red blood cell antibodies. Those things torment blood bankers so much, to say nothing of our patients, of course. Chris has published multiple articles about this very issue, and I think that you'll find his viewpoints interesting and maybe a little bit surprising. That episode is coming very soon, and I'm super excited for you to hear it. But until then, as always, I hope that you smile and have fun, and above all, never, ever stop learning. We'll catch you next time on the podcast.